Noam, a 33-year-old male, comes to the clinic after trying to conceive a baby with his wife for more than a year with no luck. Noam is very thin and quite tall. Upon physical examination, you notice that his testes are smaller than normal and he has enlarged breast tissue. In addition, Noam doesn't seem to have much facial and pubic hair. You decide to run a blood test which reveals that Noam's testosterone and inhibin B levels are decreased while gonadotropin and estrogen are increased. In addition, you perform a karyotype analysis on his cells and find 47 chromosomes, among which there's 2 X chromosomes and 1 Y chromosome. Next, you see Hadis, a 17-year-old girl who's worried because she hasn't gotten her first menstrual period yet. The first thing you notice is that Hadis is quite short for her age. Upon physical examination, she has a webbed neck, a broad chest, and poorly developed breasts with widely spaced nipples. In addition, you notice her ring fingers are very short. A blood test shows low estrogen levels and high gonadotropins, and a karyotype analysis reveals only 45 chromosomes, with 1 X chromosome. Okay, based on their presentation, both Hadis and Noam seem to have some sort of disorder of sex chromosomes. Now, humans typically have 23 pairs of chromosomes, so 46 total, out of which 22 pairs are autosomal and 1 pair consists of sex chromosomes, which can be X or Y. Generally, an individual with 2 X chromosomes, or 46XX, is considered to be genetically female. However, only 1 X chromosome gets expressed and the other is inactivated through a process called X inactivation or lionization, becoming a bar body. On the other hand, an individual with 1 X and 1 Y chromosome, or 46XY, is genetically male, and since there's only 1 X chromosome to begin with, there's generally no bar body. Now, individuals with sex chromosome disorders have aneuploidy, meaning that there's a missing or extra sex chromosome. Most often, this results from non-disjunction, which can occur in the egg or sperm cell during meiosis 1 or 2, where a chromosome pair or sister chromatid, respectively, doesn't split apart. So, the child of this individual could either receive 2 chromosomes from that parent and 1 more from the other parent, resulting in trisomy, or no chromosome from that parent and 1 from the other parent, resulting in monosomy. Less frequently, non-disjunction may occur during mitosis, where a sister chromatid doesn't separate. Now, sex chromosome disorders may result in hormonal imbalance and abnormalities in sexual development, which is normally under control of the hypothalamus-pituitary-gonadal axis. First, the hypothalamus secretes gonadotropin-releasing hormone, or GnRH for short, which goes to the anterior pituitary to stimulate the release of gonadotropic hormones, which are luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH. LH and FSH then stimulate the gonads to produce sex hormones. In males, LH stimulates the Leydig cells of the testes to secrete testosterone, and FSH stimulates the Sertoli cells to secrete inhibin B. Testosterone and inhibin B are responsible for the development of male primary sexual characteristics, which are the changes necessary for reproduction, like enlargement of the penis and testes, as well as male secondary sexual characteristics that aren't required for reproduction, like a deepening of the voice and increased muscle mass, and a male pattern of hair growth on the face, chest, axillae, and genital areas. On the other hand, in females, LH and FSH stimulate the ovaries to secrete estrogen and progesterone, which are responsible for the female primary sexual characteristics like ovulation, menstruation, and uterine development, as well as female secondary characteristics like breast development, hip widening, and hair growth mainly on the axillae and genital areas. Now, once sex hormones have done their job, they signal the hypothalamus and pituitary to turn off the secretion of GnRH, FSH, and LH. Alright, now back to sex chromosome disorders, which include Turner syndrome, Klinefelter syndrome, and XYY syndrome. Let's begin with Turner syndrome, which is characterized by having 45 chromosomes with only 1 X chromosome. So, individuals are genetically females. In most cases, this happens when a non-disjunction event occurs during meiosis of the paternal gamete, so that the sperm cell lacks a sex chromosome. An important thing to note is that since there's only 1 X chromosome, there's no bar body. Conversely, if the non-disjunction occurs after formation of the zygote during mitosis, the result is a mosaic karyotype, meaning that some cells are 45X and others are 46XX, or in a few cases, even 46XY. For your exams, you should recognize some clinical features that are characteristic for Turner syndrome. Firstly, infants may have a variety of congenital malformations. These can include a horseshoe kidney, which is when the two kidneys fuse at the bottom, forming a U shape, as well as cardiovascular abnormalities, like bicuspid aortic valve and coarctation or narrowing of the aorta, which are the most common causes of death in childhood. Another very common finding in infants are lymphatic defects, such as lymphedema or swelling of the hands and feet. Many also develop a cystic hygroma, which is an abnormal swelling on the back of the baby's neck due to lymphatic fluid buildup, which eventually decreases as they age. This often leaves extra skin on the neck, called a webbed neck, that's wider than normal. Additionally, mosaic individuals with some 46XY cells are at increased risk for gonadoblastoma, which is a complex neoplasm of gonadal components. Now, the X chromosome also carries genes that are important for growth and development of tissues throughout the body. One of these is the short stature homeobox, SHOX for short, gene. So having a single copy of the SHOX gene results in, you guessed it, short stature. Other characteristic features include a shield-like or broad chest and extensively spaced nipples. Additional features include shortened fourth metacarpals, or ring fingers, low-set ears, and arms that turn outward at the elbows, also called cubitus valgus. During puberty, there's minimal pubic hair, breast, and uterine development, as well as ovarian dysgenesis or abnormal development, leading to streak ovaries, which develop white atrophic fibrous strands. As a result, females with Turner syndrome produce decreased levels of estrogen, which leads to increased levels of both LH and FSH. Because of this, Turner syndrome is the most common cause of primary amenorrhea or absence of menstruation, and thus individuals are said to reach menopause before menarche. As a consequence, many females with Turner syndrome are infertile. Keep in mind, though, that pregnancy may be possible in some cases through in vitro fertilization or treatment with exogenous estradiol 17-beta and progesterone. Diagnosis of Turner syndrome can be confirmed via karyotype analysis, and treatment usually involves growth hormone therapy during childhood to promote bone growth, as well as sex hormone replacement therapy starting at puberty to promote breast and uterine development. Okay, our next disorder is Klinefelter syndrome. These individuals have an additional X chromosome, so they're 47XXY and are considered genetically males. Keep in mind that some individuals with Klinefelter syndrome may have a mosaic karyotype with a mixed 47XXY and 46XY karyotype, which results in a milder presentation. A very high-yield fact is that since there are two X chromosomes, individuals with Klinefelter will present a bar body. Now, Klinefelter syndrome typically presents with hypogonadism, meaning there's reduced or no hormonal activity of the testes, leading to dysgenesis or abnormal development of the seminiferous tubules. As a result, there's a decreased secretion of inhibin B by the Sertoli cells and testosterone by Leydig cells, respectively, causing increased levels of FSH and LH. And this, combined with the extra X chromosome, leads to increased estrogen production. Symptoms of Klinefelter syndrome are most apparent around the time of puberty. Typically, individuals with Klinefelter have a characteristic unicoid body shape, meaning a tall and slim body with long extremities. In addition, they have reduced muscle mass, less facial, body, and genital hair, and they often develop gynecomastia or enlarged breast tissue. A very important finding is testicular atrophy, which means that the testes are smaller than normal, and spermatogenesis or sperm production can be greatly impaired. As a result, most individuals with Klinefelter syndrome are infertile. Diagnosis of Klinefelter syndrome can be confirmed via karyotype analysis, and treatment usually involves testosterone replacement therapy, and infertility treatments can make reproduction possible in some cases. The last sex chromosome disorder is XYY or double Y syndrome. Here, there's an extra Y chromosome, so affected individuals are 47XYY and are considered genetically males. What's high yield is that typically these individuals are very tall and may develop severe acne during puberty. In addition, some may have learning disabilities or autism spectrum disorder. However, bear in mind that individuals with XYY syndrome are otherwise phenotypically normal and generally don't have any fertility problems, so they often go undiagnosed. If suspected, diagnosis can be confirmed via karyotype analysis. Alright, as a quick recap. Disorders of sex chromosomes occur when there's a missing or extra sex chromosome. Turner syndrome affects genetically female individuals that have a 45X karyotype with no bar body. Important clinical features include a short stature, a webbed neck, shield-like chest with extensively spaced nipples, and shortened fourth metacarpals. In addition, there can be congenital malformations such as a horseshoe kidney, bicuspid aortic valve and coarctation, and lymphatic defects. And most importantly, Turner syndrome causes ovarian dysgenesis with streak ovaries, which may result in amenorrhea and infertility. Klinefelter syndrome affects genetically male individuals that have a 47XXY karyotype with a bar body. Important clinical features include unicoid body shape, less facial and body hair, and gynecomastia, as well as hypogonadism that causes dysgenesis of the seminiferous tubules and testicular atrophy, which may result in infertility. Finally, XYY syndrome affects genetically male individuals that have a 47XYY karyotype. These individuals are usually very tall, have severe acne, and may have learning disabilities or autism spectrum disorder, but are otherwise phenotypically normal. Okay, back to our cases. Noam is a 33-year-old man that hasn't been able to conceive a baby with his wife, which means that he might be infertile. This is probably associated with the fact that he has testicular atrophy. In addition, he has little facial and pubic hair, gynecomastia, and he's very thin and quite tall, which are characteristics for Klinefelter syndrome. Another important clue is given by his blood tests, which reveals that Noam's testosterone and inhibin B levels are decreased, while gonadotropin and estrogen levels are increased. Finally, diagnosis of Klinefelter syndrome is confirmed via chromosome analysis showing he has a 47XXY karyotype. Next comes Hadis, a 17-year-old girl with amenorrhea. Some helpful findings are her webbed neck and her shortened fourth metacarpals. But the key here is her short stature combined with her shield-like chest, poorly developed breasts, and widely spaced nipples, which are very specific for Turner syndrome. This suspicion is supported by her blood test, which shows low estrogen levels and high gonadotropins. Finally, diagnosis of Turner syndrome is confirmed via chromosome analysis, which reveals a 45X karyotype.